Hello, my name is Dr. Neil Phippen, and I'm a gynecologic oncology fellow in the Washington, D.C. metro region. As part of the 2014 Globe-athon events, I'm here to present a presentation detailing the clinical overview of vulvar cancer. I want to begin by defining the vulva. In this picture, you can see that the vulva is really the area of the female body between the mons pubis and the anus, which includes the skin of the clitoral hood, the clitoris, the labia majora, labia minora, the urethral meatus, which is the opening to the urethra, the hymenal ring, the vaginal introitus, the perineum, and the anus. To begin, I want to go over a roadmap of the talk today. We'll discuss briefly the epidemiology of vulvar cancer, the cell types involved in vulvar cancer, how vulvar cancer is diagnosed. Then we'll discuss some treatment and the traditional outcomes associated with vulvar cancer based on stage. To begin with, I want to discuss the epidemiology of vulvar cancer. Vulvar cancer in the United States occurs in approximately 1 in 406 women. There's approximately a 1 in 406 lifetime risk of vulvar cancer. In the United States in 2014, we anticipate just under 5,000 new vulvar cancer diagnoses. This makes vulvar cancer the fourth most frequent gynecologic malignancy behind uterine, ovarian, and cervical cancer. Risk factors for vulvar cancer include older age. Predominantly, this is a disease of postmenopausal women. Infection with the human papillomavirus, also known as HPV, cigarette smoking, immunosuppression, such as AIDS, a history of cervical cancer or cervical dysplasia, prior vulvar inflammatory lesions, such as lichen sclerosis. Protective measures that a woman can take to avoid vulvar cancer would include avoiding cigarette smoking and taking measures to prevent HPV infection. Next, I want to discuss the different cell types involved in vulvar cancer. As you may have noted on the first slide showing the anatomy of the vulva, vulvar cancer is cancer of the skin overlying that area, and the vast majority of that skin is squamous epithelial tissue. Therefore, greater than 90% of primary vulvar tumors arise from that squamous cell tissue. In younger patients between the ages of 40 and 60, where we've recently seen a slight increase in the incidence of vulvar cancer, this disease is believed to be largely driven by HPV-related changes and HPV infection. In the older patients where vulvar cancer is more traditionally diagnosed between the ages of 70 and 80, this is an inflammatory-mediated disorder in patients most often that have had lichen sclerosis or other inflammatory cell-mediated irritation to the vulva. In 8% of vulvar primary tumors, the tumors arise from malignant melanoma, and this is most commonly diagnosed in Caucasian women. Other cell types in the vulva include basal cell carcinomas, adenocarcinoma of the Bartholin's gland, Paget's disease, sweat gland carcinoma, and sarcomas, although these cell types are extremely rare. How is vulvar cancer diagnosed? Oftentimes, a patient will present with symptoms such as itching. They may recognize a visible lesion or a mass. Sometimes there's a swollen lymph node or multiple lymph nodes in the groin area. Patients with advanced disease or even very localized disease, just with a focal obstruction of the urethra or the vaginal opening. Patients may also recognize changes to the skin color of the vulva that prompts seeking medical attention. On physical exam, it's very important that a physician is able to evaluate the cervix and the vagina, as cervical cancer is much more common than vulvar cancer, and the purpose of this exam is to verify that there is not a primary cervical lesion and that what's seen on the vulva is not a metastatic lesion from the cervix. Additionally, during physical exam, the physician will want to evaluate the lymph nodes in the groin as well as other lymph nodes in the body to make sure there are no enlargements suspicious for metastatic disease. Additionally, your provider may recommend imaging such as CAT scans, MRIs, or PET scans, which can be helpful to evaluate the dissemination of vulvar cancer and the presence of metastatic lesions. PET scan, in particular, may be useful for evaluating clinically normal lymph nodes for evidence of metastasis. Biopsy is the gold standard of diagnosis, however. Of course, the primary lesion on the vulva needs to be biopsied, but additional areas of concern for metastasis, such as a lymph node that would be enlarged on physical exam, could also be biopsied to confirm metastases. Vulvar cancer is a cancer that is staged surgically, meaning that you cannot designate a stage for vulvar cancer using radiographic information. Surgical staging is required for giving the exact diagnosis. Stage 1 vulvar cancer is confined to the vulva itself and is broken into two groups. Stage 1A, which consists of a smaller lesion less than or equal to 2 centimeters in size that is very superficial with less than or equal to 1 millimeter of stromal invasion and has no lymphatic spread. A 1B lesion is greater than 2 centimeters in size, but again, very superficial with less than or equal to 1 millimeter depth of invasion. It also has negative lymph node spread. Stage 2 disease can be considered limited local spread and may include spread to the lower 1/3 of the urethra, the vagina, or the anus. Again, most importantly, there is no lymphatic spread in stage 2 disease. Stage 3 disease involves lymphatic spread, and this is lymphatic spread to the inguinofemoral lymph nodes, which are located in the groin creases on either side. Stage 3A1 represents one positive lymph node with a focus of disease greater than or equal to 5 millimeters. Stage 3A2 would be two positive lymph nodes with focuses of foci of disease less than 5 millimeters. 3B1 represents two positive lymph nodes with disease foci greater than or equal to 5 millimeters, while a 3B2 lesion would entail 3 or more positive lymph nodes with disease foci less than 5 millimeters. Patients with 3C disease would have lymphatic node spread with the disease actually breaking through the capsule of the lymph node. Stage 4 disease is broken into 4A and 4B. 4A represents regional metastases and is further subdivided into stage 4A1, where disease can spread to the upper 2/3 of the vagina or urethra and may include the bladder mucosa, rectal mucosa, and even the pelvic bone. 4A2 disease is disease that would be causing fixed or ulcerated inguinofemoral lymph nodes. In stage 4B disease, you truly have distant metastases to include any intra-abdominal structures, pelvic lymph nodes, or lungs. The treatment for vulvar cancer relies heavily upon surgery. Surgery is has two purposes at the minimum. One is for comprehensive staging, and two is for treatment. Surgery can range, depending on the size of the lesion, to between a wide local excision or radical vulvectomy, where the entire skin of the vulva is removed. The goal, regardless of surgical type, be it more conservative or more aggressive, is to obtain 1 to 2 centimeters of negative margins. Additionally, at the time of surgery, evaluation of the lymph nodes is crucial. This may range from a sentinel lymph node evaluation, where the primary lesion is injected with a dye or a radioactive substance that can be traced to the most proximal lymph node, allowing that lymph node to be resected and evaluated for metastatic disease. And if that lymph node is negative, that may be the only lymph node evaluation necessary. If that lymph node is positive, or if a patient has large, bulky disease at presentation, a full lymphadenectomy on one side or both sides may be required. Radiation is also a very important part of treatment for vulvar cancer. In the preoperative setting, patients that have extremely large, bulky tumors may benefit from preoperative radiation to shrink the tumor such that the surgical resection can be less radical. In the postoperative setting, radiation may be necessary depending on the surgical margins, the size and depth of the tumor, and positive lymph nodes. It is important to note that although radiation is effective in and of itself, patients often are prescribed chemosensitization with cisplatin to coincide with radiation treatments. And this is largely based on evidence from cervical cancer, where in squamous cell cervical cancer, chemosensitization with cisplatin makes the cells much more responsive to radiation treatment. Chemotherapy in vulvar cancer really plays a limited role in the recurrent setting. Next, I want to discuss briefly some of the specific complications related to vulvar cancer, beginning with surgery. It's important to remember that the more radical the surgery, the more reconstruction that would be needed. Oftentimes, plastic reconstructive surgery is necessary to restore anatomical normality to the vulva after a big radical resection. It's important to note that there are often cosmetic and functional deficits following these surgeries, and unfortunately, based on the area of the anatomy where this cancer often arises and this surgery is performed, it is prone to wound breakdown and infection. Also, when lymph node resection occurs, if a full lymphadenectomy is performed, patients are at high risk for lymphedema in one or both legs, depending on if lymph node resection is performed unilaterally or bilaterally. Lymphedema is a buildup of lymph fluid in the leg, causing swelling of the complete extremity. It can be quite painful. Patients that undergo radiation are also at risk for complications. In the acute setting, during radiation and immediately after, a high likelihood of patients experiencing local irritation, such as mucositis, which is inflammation of the vaginal mucosa or the anal mucosa, or also squamous desquamation. Late months to years after radiation therapy is completed, late complications could include femoral head fractures or skin ulceration. Lastly, I want to briefly discuss the anticipated outcomes of vulvar cancer. In oncology, we think of 5-year survival rates, and in vulvar cancer, it's important to note that positive lymph nodes are a poor prognostic factor and endow a 50% decreased 5-year survival. Therefore, for stage 1 and 2 disease, 5-year survival is pretty good at 80 to 90%. In stage 3 disease, which implies lymph node metastases, 5-year survival may be in the 40 to 50% range. Stage 4 disease is oftentimes less than 20% 5-year survival. Disease recurrence is a reality for all cancers and no different in vulvar cancer. When disease does recur, it is classified as either local, recurrent in the groin, or recurrent distantly. This is important to make these distinctions because local recurrent vulvar cancer can often be cured with additional surgery and perhaps radiation. However, groin and distant recurrences have very poor prognoses. This concludes my clinical overview of vulvar cancer. I hope that you have a better understanding of the disease risk factors, cell types, symptoms, diagnosis, and treatment for this disease entity. I encourage you to get more information from your physician and these websites that I have listed here. The Globe-athon website has a library of informative videos with further details on topics I've discussed today, as well as other topics such as radiation and chemotherapy. Thank you.